Welcome everybody to this session where we're going to shine a light on nursing, allied health professional and social care worker research, particularly around obviously the palliative and end of life. And just introduce myself, I'm Susie Pearce, and Candy McCabe and Matthew Maddocks are also going to present in this webinar. We'll introduce them properly when we get to the session. So the aims really of this is to provide an overview of the opportunities for nurses, midwives, and allied health professionals and social care workers to explore and develop research capacity, to share some of the impact and potential of clinical academic careers and the opportunities and contribution that the underrepresented professions, which we all are, in palliative and end-of-life care can make, and just to demonstrate some of the support and the networks available for your next steps via the NIHR Palliative Care Research Incubator in particular, but NIHR more generally, and in terms of using research as well to develop capacity and capability. So that's the aims of the session. I'm going to start by talking about opportunities for nurses and allied health professionals and social care workers more generally, really giving a bit of a landscape of where we are and what some of the wide opportunities are that people can tap into. So there's been a plethora of policies and documents sort of building the importance of nurses, midwives, and allied health professionals in terms of research and research capacity building. This started in 2012, and there's been quite a few documents in the last couple of years. So there's a real UKRI, which is the one at the bottom, really trying to embed and support our professions to be able to develop research and to develop clinical academic research in particular. The AUKUH document there, Transforming Healthcare Through Clinical Academic Roles, is a few years old, but I still really recommend it if you're sort of beginning and want to just explore how to go about developing sort of clinical academic roles in healthcare organisations. So part of the reason why there's been a big impetus for this area is because of the evidence that developing research active organisations and research active workforce achieves better patient outcomes, better organisations of care with an impact across the workforce in terms of recruitment and retention and across the wider system. So that's been a real impetus for the need to develop this area. And there's been more research in the last few years. You can see some examples here, just looking at some of the barriers and the enablers, the challenges and the aspirations of developing research in health and care organisations, and particularly for nurses, midwives, and allied health professionals. So I really recommend sort of delving in and having a look at some of the literature, which has been growing quite considerably in the last few years. So that in the last 2 to 3 years, there's been a lot of strategy and policy implementation to really support nurses and allied health professionals and midwives in this space. And the more recent 10-year plan really does embody the importance of research and research leadership within our professions. So that's very encouraging. And the workforce plan is going to be due out, I think, in the spring. So hopefully that will articulate this area even more. The Chief Nurse Officer for England had a big strategy document called Making Research Matter. And you can see the boxes on the left-hand side really articulating some of the areas where this is really key and where there's been a lot of strategy and support through chief nurses and all the way through organisations to make some of this happen. On the right-hand side, you can see the Allied Health Professional Strategy and the Chief Midwifery Officer for England's Strategic Plan for Research. So all of them are aligned and all really important to make the case to make change within our own organisations where we work. Some of the tools that have come out of these that support the work is a self-assessment organisational readiness tool, which is really useful if you're working in a team or a setting where you're beginning to start to want to develop research and research capacity and capability across the workforce. Really good way to see where you are now, and maybe some of the steps for improvement and to changing culture, which is obviously key. There's a research toolkit for matrons and other health and care leaders, which is again a really useful tool to support that leadership that we need at a local level to develop research careers and research capacity and capability. And then more recently, there's been a strategic supporting document for executive chief nursing officers, which is really key, because we have found in some of the research that we've done in the Southwest, you can see the triangle on the right with interviews with chief nurses, how important they are to supporting this area. One, they have the exec responsibility, but also I think many of them have a passion and really want to lift others up and drive that positive research culture. So it's really important we can support those at the top of organisations that really need to drive this. So clinical academic nursing, midwifery and allied health professionals is really important. A sort of element of this is the development of clinical academic careers. So that means that we can work clinically and actively work as health researchers at the same time. This is often as joint appointments, although there's been a lot of problems in terms of equity and equality and moving between higher education and clinical practice, and having perhaps some of the same rights and pensions and other responsibilities as medics have more established clinical academic career pathways. But clinical academics are really key to have people doing research in practice, to lead and inspire others, to be able to really see and understand new ways of delivering better outcomes from the ground up. So understanding those day-to-day issues, to be able to identify questions that are important, and to be able to challenge current thinking. So really important, I think, to be able to drive that way to support that clinical academic research career pathway rather than having to choose between the two. You can see here, you can see the awards and the allied health professionals, nurses, social workers, midwives in terms of the proportion of awards that they have got per year. It's 0.1% of nurses, midwives and AHPs are clinical academics, and there's a real drive to increase that and to increase the numbers of who are successful with their awards. So there's way to go, but there is some progress that's been made already. So more recently, and very recently in this year, the UKRI, which is the United Kingdom Research Institute, have developed a real plan for where we need to be, which is to develop clear research routes to really enable the number to increase, double in the next 5 years, to create that culture environment that supports clinical academic careers and embed those processes to support equitable pay and conditions, which is really key, and ensure that nurses, midwives and allied health professionals really are key on the decision-making bodies so that progress can be monitored. So that's also really important. So just really to look at some of the opportunities that are there. The National Institute of Health Research has been, in the last 15 years, has been really central to supporting research capacity and capability building and to supporting careers and clinical academic opportunities. And this is through career development awards and support, through training and support for practitioners and clinicians and clinical researchers, and also training and support for research delivery staff, which I'll talk a bit less about now, but is really important. And obviously that blending and movement between all of these three is really key. So clinical academic careers, just a quick snapshot on some of the opportunities. There's a pathway from pre-masters or internships, and there's funded internships. NIHR have internship program, which I'll have a slide on a bit later. Clinical masters, and the Insight program is a program that you'll find in your areas, in your regions, with some of the universities that are near you, which is an opportunity to develop and have funded masters in clinical research. then a clinical doctorate research fellowship, so doing a PhD whilst still working clinically, and then further on clinical lectureships and senior clinical lectureships. So there's opportunities between these in these nationally funded fellowships to be able to stay in practice and to be able to develop your research career. Some other opportunities in terms of supporting leadership and capacity and capability building are through this research leader program. I'm not sure if you've come across these, but really key. There's a senior research leader program, which I think has just been announced, the next round. I think we're on the third round. The Developing Research Leader program is open. So have a look at that if you've not looked at it before. And that funds people 2 days a week for 3 years to have a role in developing a leadership role to support their team or their organisation in terms of research capacity and capability. So really key. And I think specialist palliative care, other social care, community care, other settings other than acute trusts where they're really looking to put these research leaders in now. So really good opportunities, I think, to be able to get people and time in your organizations to be able to support others and to support that culture. Another one at the bottom, the Senior Clinical Practitioner Research Award, is for postdocs. So there's a real also drive to make sure that we keep people that have got PhDs who have done some research and still in practice to be able to stay in practice. So that's a real drive, and this is one of those awards that can support that. I did mention the NIHR internships. These are just examples for the Southwest Peninsula, but there will be NIHR internships and NIHR Insight programs where you are. And so to really look at those are really important. The internships are a really good first step into research and fun time to sort of do some of that initial exploration, PPI work, and just seeing whether this is an area that you want to develop further. And yeah, a last one. So the RFPB is a Research for Patient Benefit program. So this is research funding. But there's a call open now, which closes, as expression of interest closes in a couple of weeks, which is for nursing, nurses and midwives. And that funds projects concerned with day-to-day practice and health and social care. So really great opportunity to support early career researchers. And there'll be, following on from this, there'll be an allied health professional one. So something else to look forward to and to look to develop towards being able to apply for one of these as well, because they're great opportunities to actually embed research in practice. So that's all we've got time for now to talk about the awards, but do look at NIHR. There's lots of websites and information. If you just Google those awards, you'll find the websites and everything you need to know. Just also in terms of supporting you is the importance of networks. So you'll find geographical, professional, specialist networks in your area. This is an example of developing research skill workforce. This is a network we have across the Southwest region, but there'll be networks wherever you are that are there to support research careers and clinical academic pathways. Here's an example here of the National Allied Health Professional Network, and Karen is a National Clinical Academic Roles Implementation Network. So there's lots of places to go and to get involved and connect in and get support and help. In terms of specialist networks, Candy is going to talk about the Palliative Care Research Incubator later on in this session. So that's obviously going to be really important for you who are here at the Mary Curie conference. So that's all I've got to say here for now. In terms of an introduction and of shining a light on some of the opportunities for nurses, midwives and allied health professionals. And I'm going to hand over to Matthew now. Matthew Maddocks is a professor at King's College London to talk about some more specific examples in terms of embedding and using research. So shall I move on to your slides,
Yeah,
Matt?
please. Thank you. Excellent. Thanks, Susie. And I can also note, I can see a question already in the question and answer section, and we'll take all of the questions for a discussion at the end. But just to encourage everyone to add your comments and questions to that during the talk, so we've got plenty to start that discussion. So my name's Matthew. I'm a physiotherapist by training, so one of the allied health professions, and I'm a professor of health services research and rehabilitation. In the next 15 minutes, I want to tell you a bit about a research project which is coming towards an end, and help you realize that you can use ongoing research that's happening in your area and happening around you as a way to build research capacity. And that's by no means in conflict with all of the things that Susie has talked about and all of the training and networking opportunities that you'll hear about from Candy, but just to help people appreciate that projects themselves also build research capacity in our specialty. Next slide, please. And the project I'd like to tell you about is called Inspire. There's many projects which are funded by the European Commission. This is one of them. And this is a project about providing routine and regular rehabilitation to people with incurable cancer diagnosis. And at the moment, that population will get quite varied and sporadic access to rehabilitation. It will differ depending on the type of cancer they have, the country that they're in, and the setting which they're receiving care within. And this project is really testing if we offer routine rehabilitation, what does that do for someone's quality of life in the context of an incurable cancer? Because of the rehab focus, there's lots of interest and indeed relevance to many allied health professions and nursing, in that rehabilitation is really a focus of care that attends to people's function, their symptoms and their mobility, and how they participate in everyday activities. So it's not a term or a specialty which is professionally owned, but many allied health professions have got expertise and interests in rehabilitation provision. And you can see from the picture, this is maybe 2/3 or half of the people who are involved in the project. It's spanning different countries, and it's spanning lots of different perspectives and professions and expertise that come into the project. And lots of this project you'll hear is about learning from each other to test quite a simple idea across a range of different settings. Next slide, please. And the kind of overview of the project, just to give a context, is really revolving around the main trial. So we're undertaking a randomized controlled trial, or an RCT, which is testing that question around rehabilitation and its effect on quality of life. Before the trial, we have these, they're called work packages. One of them is comparing different services across the countries and in asking questions about how palliative care interacts and integrates with oncology services, and also how those two parts of someone's care provision interact with rehabilitation. And also something around intervention readiness. I'll talk about this in a moment, is how we ensure that what we're testing in the study is similar and can be compared across settings. And then towards the end, there's lots of building of the evidence and building consensus around the topic area once we've done the different analyses. So in the whole, it's a randomized trial with a bit of research before and after that taking place. Next slide. And then lastly, as a background, is just a schematic of the trial and what we're testing. So we're recruiting, or we've recruited, should I say, quite a large number of people, 340 people to our trial. And those will be randomly allocated to usual care in the control group. So they'll get their oncology with palliative care. And of course, we're not denying any access to rehabilitation in the study, or they'll get usual care plus the rehabilitation intervention. And there are many design choices, and a lot of that is kind of the experience and again, that part of capacity building in the work. But we've got very broad eligibility criteria because we're asking quite a general effectiveness type question that we want to be generalizable to the whole population. And we're measuring quality of life after 8 weeks. And the balance of that time point is it's short enough that this population will be able to be around and give their outcomes at that time point, but also gives us time to give an appropriate dose of rehabilitation so that we're asking what we want to do with the research question. Next slide. So I want to pick up on different aspects of the trial and project experience, and to highlight how those themselves have built a lot of capacity in the people who are involved in the trial delivery, but also in everyone in the consortium, the group of people undertaking this research, and also many people in the organizations which the research has taken place. So this slide just shows the kind of progress and tracking of our recruitment. And there's a really impressive and concerted effort from each of the sites who took part in this research. You can see everyone on the right-hand side who was joining the research study has contributed a good deal of people and allowed them to take part in the study. And we're pretty close to what we expected and hoped would happen. This was definitely the result of everyone's kind of hard work and then the leadership from our clinical trials unit. But thinking about research capacity, at the level of the research sites, for each of those people, there's more awareness and exposure, and then learning around how research and clinical methods can be delivered in the practice site, around some of the kind of culture and ethos of evaluating care within the context of research, and helping also kind of streamline people's processes to help deliver and conduct and then share the findings of research into their practice. So behind all of these kind of delivery trials, there's a lot of hard work from individuals and from organizations, and there'll be lots of very informal and kind of tacit research capacity building as a result of that. Next slide, please. The other aspect which was within some of those sites and is actually a really exciting offer from NIHR is called the Associate PI scheme. So a principal investigator is the person that holds the responsibility for delivering research in a site. And it's often a role which is given to people who've got experience of doing that before. And it's something which is not always allocated to allied health professions or nursing staff. The associate PI scheme, which we joined as a study, allows people to work alongside a more experienced staff member to be responsible and to shadow their undertaking of this role within the study. And over 6 months, they get some on-the-job training experience and they create a learning log. And after that, they get a recognised certificate, which is recognised both from the NIHR and then all of the Royal Colleges, which come from their respective professions. So in that sense, they've got a certification and some quality assurance that they're ready to take on this role when the next offer of research comes about. And we talk a lot about the research delivery network and the portfolio of research studies. And this particular scheme has built capacity among these individuals who are now kind of prepared and quality assured and ready to take on that principal investigator role in delivering other research. Next slide. The other group of really important, absolutely paramount people to this kind of research is the practitioners who are delivering the rehabilitation intervention. And it's often fairly demanding skill and something that people have to navigate to do what's quite familiar to them in many aspects of how they would offer care and how they would look after this patient population. But to be asked to manualize that and to do it in a more of a standard and structured way, not that they weren't structured before, but this is structured relative to the study and the trial question. And we've had a really impressive community of practice in a team of people who have delivered this intervention across the different countries. And that's afforded, again, these people to get really familiar with experience and confidence in undertaking and delivering research, in thinking about how research evidence is generated and then how they might apply that to their practice. And then also in gaining a kind of confidence around questioning and disseminating their experience around undertaking research. So from a trial perspective, this has helped us ensure that what we're delivering is standard and the countries and the sites are all doing something similar. So the trial is more uniform. But each of these individuals has got a kind of an offer of some really excellent peer support, some really excellent information exchange around clinical delivery, but also around research conduct and practice. And many of them have kind of had really interesting journeys through the study, and they've really gained confidence and a really healthy questioning of their work. So their research capacity is undoubtedly improved, and they're also disseminating many of the findings locally. Next slide, please. The other important aspect of the research, and I think is something we were able to lead with a bit of experience from the UK, but it's also something from our Danish partners have driven this part of the work, is around research inclusion. And of course, there's lots of capacity to be able to be inclusive in how you design and deliver and disseminate research. For this study, we had a kind of structure where each site had to think really carefully with their research delivery roles, their research nurses and research practitioners, about how to make this study as accessible as possible. So it looks like, and it sounds like, and it reads like something which each person in their catchment area in their population is interested in and would like to take part and have a good experience through the study. So we each had these equitable inclusion plans. We shared really good practice of how cases were helped to take part and invited to join the study, and the different ways people supported them. Those were shared through the study newsletters. And then at the end, we had a World Cafe, which is like a kind of structured focus group exercise where people share their reflections and share their examples of good research inclusion. So again, capacity in this study has been built, and there's been many good learning from one person to another, and from one site to another, and from one country to another. Next slide. The next one is much more traditional, but it makes the point that if you've got quite substantial projects, then they help many people to undertake formal training and qualifications, including in research. So through this project, we've got 6 people who have started, and some of them have either submitted or they're just about to submit their PhD thesis. And they've joined in the overall effort and contributed to the delivery of the project. And then they've also taken a particular area of interest. So as an example, Megan is looking at cachexia or muscle wasting with cancer. Mina is looking at mobility and how that changes. And Amy, as another example, Amy's a dietitian and is looking at nutritional screening and nutritional care as part of this. So there's a lot of a good volume of kind of capacity building through formal research training and PhDs. And then the last slide is around capacity building, again, in a fairly informal way, but a lot of this is about the capacity of our particular field, and we wrestle as a group about this term of palliative rehabilitation and whether that's a thing. If it is, what features does it have, and how is it different from other models of rehabilitation? But it's also helped us collectively to be able to kind of build our science and then articulate the role for rehabilitation specialists and allied health professions to palliative care. It's helped us be quite clear as a group about the policy implications of what this might mean. And it's helped us to kind of describe the relevance and the value of this work. And then if you just do 2 slides, Susie, the last one is a place where you can go if you're interested just to learn more about this project. And again, from an inclusion point of view, all of the languages who are involved in this study, the resources are available throughout. And we're building a training program, which again will help people to understand how research has taken place in this form, and how people can build this particular topic and specialty. So thanks all for listening, and I look forward to the discussion later. Muted.
Sorry. Yeah, just to thank Matt and to just remind everyone to put their questions in the Q&A and we'll come back to them all later. That was really inspiring piece of work. So Candy, we're going to come on to you. So introduce Candy, who's a professor at Dorothy House Hospice, and she's also the co-lead of the Palliative Care Research Incubator. So she's going to tell us some more about that now.
Lovely. Thanks, Susie. Good afternoon, and thank you everybody for staying on for this final session of the conference. So it's great to be here. I'm also a nurse and have worked as a clinical academic researcher for many decades now, and really delighted to now be co-leading the NIHR supported palliative research incubator. And I co-lead it with my wonderful partner, who's Professor Christina Fall, who many of you will know from the world of palliative end-of-life care. She's a retired consultant in palliative and end-of-life care. So together we have launched this along with many others in our community, and this started last July was the beginning of it, and I'm here to tell you all about the free accessible resources available to you and to encourage you to become a member. So thank you, Susie. Next slide, please. So where are we at in palliative end-of-life care research? And Susie's already given a bit of an insight into how nurses, allied healthcare professionals and social care professionals are very much under-recognised in research awards. But we know in particular in this speciality, we have received very little research funding at a national level. And you can see that just in the last 5 years, less than 3% of those personal awards and fellowships from the NIHR have come to our particular specialty. We also know that there's unfortunately a large lack of ethnic diversity in some of our senior research leaders, and that there's inequity in access to research for the people that we're caring for within this profession. I myself work at Dorothy House Hospice, where I lead education and research, but only a quarter approximately of hospices are research active, and they access a huge community, rural communities, who are not benefiting from research that could potentially be improving their lives, or certainly the lives of future populations being cared for within hospices. Thanks, Susie. So on that background, we were able to get support from the National Institute for Health Research to create an incubator for our specialty. Now, incubators is quite a strange word and something that many of you may not have come across, but these were established particularly for either professional groups or specialties where there was, for unknown reasons perhaps, a lack of research funding, a lack of research capacity and capability. And the idea is that it's short fixed term funding for 3 years, and to bring together the members of those particular professional groups or specialities to look at what are the barriers, why hasn't research taken off in their area, and to help build and support the growth of research in those particular topic areas. And for those of you who are nurses, you may remember that a few years back now, there was a nurses incubator, which did fantastic work at just recognising when nurses need a bit more support in preparing a fellowship application, for example, and giving them that mentorship and those senior role models. Thanks, Susie. The Palliative and End-of-Life Care Incubator has 3 key aims, and what we really want to do is inspire clinical and non-clinical researchers to conduct research in our specialty. The bottom line is we need more researchers in this area. We have, thankfully, quite a few senior researchers, but we have very few up-and-coming mid-career or early career researchers. And we need to grow those across the specialty and across the different professions. We all know that palliative end-of-life care requires a holistic approach, and there are many different skills that are required. And therefore, we need nurses, allied healthcare professionals, social workers, psychologists, spiritual leaders, as well as our fantastic medical colleagues. And so the aim of our incubator is to really inspire the whole workforce, whether you're based in academia or in clinical practice, to start to get into research and become curious about the things that you're surrounded by. We also want to be able to support that research development, and that's, you'll hear a little bit later about some really practical things that the community are doing to just help train up people to start to, first of all, get on that research ladder, or to progress perhaps once they've done a PhD and struggling to find a research job following that qualification. I mentioned at the beginning that incubators are on fixed-term contracts. We're just here for 3 years. There is an opportunity to do a further 3 years, but that's by no means guaranteed. But the aim of incubators isn't to be around for a very long time. The aim is to get the community equipped to be able to support itself and to build that infrastructure so that we have long-standing organisations, commitment and culture to keep research going within our specialty. Thanks, Susie. Here are just the specific objectives that we have for the incubator, and we want to be as inclusive as possible. So that's both professionally and geographically, as well as recognising any cultural barriers that there may be. We had to focus on somebody, and we've chosen to focus on early and mid-career researchers. Those are the future for our specialty, and we really need to build up people in every setting that palliative care is distributed in. We need people in those settings. We're already providing that virtual networking, those development opportunities, but a lot of signposting as well. There's a huge amount of experience, knowledge out there, but it's sometimes very difficult to find your way to it and to get into it. What we want from the incubator is that it's a one-stop shop that will signpost you to those different links and help you to go and find the right people to talk to and start your research journey. We're looking as well at facilitating mentorship. Many of you we know from our membership data already have a mentor, and I've certainly benefited from some fantastic mentors throughout my career. Sometimes that's just been a single conversation, sometimes that's been a much longer relationship, and that has been so helpful to have senior experienced leaders who've just opened doors for me and allowed me to progress on. And I think everybody benefits from that mentorship. And within the incubator, we'll signpost you to existing resources about mentorship, but also hopefully be able to start some of you on that journey with support from members of our incubator. We're actively working to create more collaborative grant applications, and that's through some of our events, but also that networking. It's amazing how once you've met somebody, heard about their research, that can inspire you and you want to get involved and work with them. And I suspect many of you, having listened to Matthew's fantastic presentation, now want to get involved and learn more about that and are inspired yourselves to go and do some research like that. And that's how this networking works, isn't it? We all find inspirational people that we want to go and work with and enjoy the outcomes and the experiences that you can gain from that. We also, as I've said, we need to be able to find a strategy that will give us that long-term sustainability so that research is integrated into palliative and end-of-life care and is the normal culture wherever you're working. Thanks, Susie. Next slide, please.
Sorry, it's stuck. Oh. There you go. Is that right?
That's it. Great.
Yeah,
so I just wanted to share with you some of the events that you can access. So if you're an early or mid-career researcher in particular, every month there's an informal networking that happens. I think it's the second Tuesday of the month, but do go onto our website just to have a look. And that is just an informal space to talk to other people, hear about what people are up to. Either perhaps they might be doing their masters, their PhD, looking for future research projects. And we also really wanted to get that group to be introduced to senior research leaders in the field. Sometimes it can feel a little bit daunting about approaching someone perhaps as senior as Susie or Matthew. And so we want to make that much easier by bringing in every month somebody, and I think actually it is Matthew next month, who will be joining that group. So please do get involved in that and either scan the QR code or go onto our website and you can see that opportunity. We also have a number of online events coming up, a huge range of different things. We try and run things as much as we can online so that people can access those from wherever they are in the country. And also within your busy schedules, these are all recorded. So if you go onto our website, you'll see all the events we've run so far. And there's a real wealth of different learning there. To become a member, sign up. It's completely free, but it does mean that you access our newsletter once a month that we'll send out to you, telling you more about all of these different events and opportunities. And also it means that there'll be some events coming up which are for members only, so it'll give you exclusive access to those things. And you don't need to have any particular research experience to come and join us. That really isn't the idea. What we want is to inspire people just to get on that research journey. But equally, if you've been working in research for many, many years, we'd love to hear from you too, because we need your expertise to help bring on those more junior colleagues. Our next face-to-face event is at the Palliative Care Congress in Brighton, where we'll be having a breadth of colleagues from the Incubator to help talk to you about a wealth of different opportunities that are there. So please do come and join us. It's in the afternoon on Thursday, the 26th of March, and we'd love to see you. We have other face-to-face events coming up as well. So again, have a look on our Incubator website. Next slide, please. Thanks, Susie. So this is our website. As I say, all the recordings are sitting there of previous events. We've got lots going on, and please do join up just to get the weekly news and be member of this really exciting community. We're obviously very closely linked to the National Institute for Health Research. We receive all of their updates as a priority, and therefore we can link you through to support that you might need as well. The NIHR is a fantastic resource, as Susie has explained in her presentation. There's lots of opportunities there. But outside of the NIHR, there's also lots of opportunities through charities. Perhaps there may be a local charity nearby, and it's just getting that research confidence and getting perhaps a bit of senior support to help you on your way. That's what we hope the Incubator will do. Thanks, Susie.
Thank you. Thanks, Candy. And thanks, Matthew. So I'm going to stop sharing now and we'll go to the Q&A. So if you can see the Q&A button, please do use that.
Thanks, Susie. I'll try and field some of the questions as they come through. There's a very helpful opening question. It says, what advice would you have for people wanting to become clinical academics? And in particular, balancing academic work with clinical commitments. I guess we could each add something to that.
Yeah, I mean it's a challenge, and I think obviously these clinical academic funding streams NIHR offer, and as Candy says, you can get from other sources, charities, really do give you that opportunity to be able to have designated time for research and designated time for practice. And I think they obviously are a great opportunity, and probably the best way to do it, I think, I don't know, Candy and Matt, but we probably did our PhDs in our own time. I don't know. So there's actually been a huge development, a huge change, and there's a huge opportunity to be able to balance both. And I think it is about keeping some of that time separate, making sure you do have your own, your time for your research and time, and making sure that you can navigate that time within your clinical situation. Sometimes there's pressure, isn't there, to go back to practice or to fill in when times are tight clinically. So I think it's really important to have that give and take, but to keep your boundaries as well.
Yeah. Andy, anything to add?
Yes, gosh, I could do about an hour on this because it's not easy, is it? And fantastic that somebody wants to become a clinical academic. It's a tough route, but really rewarding. I think the key thing is that you are working in an organisation which is supportive of you to do that. To me, seems to be fundamental, and to have immediate line managers who really understand your vision and really want you to do that. And at times I have moved organisations in order to make sure that I have that. So I think that is a crucial thing. I would also echo Susie's advice that it's really sensible to look at a funding application which will give you that time carved out. As a clinical academic, I always found that clinical work is what dominates, that is what feels the priority. So it's crucial that you do have it boundaried. And that is so much easier if you have research funding, which is buying out your time. So you can easily say to those that you're working for clinically, actually, these are my research days. It isn't easy, and I've had a sort of split roles, 2 different contracts, is the only way that I've managed it, and being fairly ruthless, which isn't easy by any means. But I would say I think the organisational support is the fundamental thing that you need as an academic and as a clinician.
Thanks, Candy. And just to add with some examples, when people finish their PhDs and often go back and get a clinical job, a lot of the useful things I can do is help them spot and then apply for quite local and small funding pots. If those come from let's say the trust charity or the trust research department, then you can link the research more directly to the particular remit and priorities of the trust. And it might not come with so much protected time, but it does mean that the effort which is used on that research is locally recognized, and also helps you build that. So I think spotting the opportunities where you can also join in with other people's research efforts or ongoing research efforts is more likely that you'll get outputs that you're part of with that work. Thank you. And then I think a related question around mentoring schemes. You mentioned, Candy, a mentoring scheme which is forthcoming, which will be very relevant to this person. But does anyone know about mentoring schemes for people that like to move into clinical academic careers?
I'm happy to start that one off. I think it's certainly once you are within the NIHR family, there's NIHR mentoring, but sometimes it's that transition bit where you're not quite sure how you're going to start that journey. And I would say go and see somebody who is doing the job that you would like in your future and contact them and say, could you give me some advice? I've never met a senior colleague who hasn't either been flattered or been very, very generous with their time whenever they've been approached by either myself or one of my colleagues to have a bit of advice. So don't be fearful of that. Do approach people who are working in a job that you would rather like, and see that that's where you want to head to. And even if it's a single conversation, then that may be all that you need. But equally, sometimes people are really happy to meet on a regular basis and just support you. As somebody who's mentored people in my career, it's really rewarding work as a mentor. So be brave, contact people that you think might be able to help you and start up a conversation, I would say.
Yeah, I think that's great advice. And I think that point that sometimes it's just a conversation, sometimes you just need 1 or 2 conversations to help you get to the next stage. Sometimes it doesn't have to always be a long-term relationship either. So I think that's important, because you can ask people to meet and have a chat about something quite easily, can't you? Or much more easily sometimes. And I think it's just those networks, the ARCs that you have in your areas, and the RDNs, the research delivery networks, all of them have networks and potentially some mechanisms for support and mentorship. So is to have a look around in your professional groups, your speciality areas, and then some of those other infrastructural supports that is provided regionally. They often do have mentorship schemes and support as well, don't they?
Yeah, thanks, Susie. And to add, when you're at, I mean, events like this, but also in person, those are quite protected spaces, and people there are very happy to have discussions. People want to talk. People want to start networking, and although that's very informal, it might be the start of some mentor-like relationship with people, and that's a much easier and more accessible and instant way than kind of approaching someone with a kind of formal "will you be my mentor?" Because these relationships sometimes are very brief and focused, and sometimes they continue and they develop over time. So do come up to people and ask your questions of them in those conferences. I'll go to one other question about the specialty. So the question reads: research contributing directly towards improving care in the near future is essential. Do you feel that research in palliative and end-of-life care setting or end-of-life care setting finds it difficult to satisfy this requirement? How does one counter claims of end-of-life care research being mostly academic in nature? I mean, I can start just by saying that what our specialty does have, in the end of life situation does have, is an immense need and immense burden on society, and there are big important problems that our research tackles. So alleviating or relieving suffering is absolutely improving care, and reducing some of the consequences of that suffering to everyone involved, the person and their family and those providing services around them. So I think there are many very real, very practical improvements in care that can be achieved with our work. But I'm not sure if the question might be about the time frame and how our research having to work in short time frames.
Yeah, and I think some of that is also to do with the methods that you use. There's much more movement to using co-design participatory methods, and or even realist methods that are very much embedded within practice or embedded within policy making, with constant conversations back into decision making as you do the research. And I think that's really important in terms of making that tangible, and quick change, to practice and policy, rather than waiting until all the papers have been written, etc. So I think there's a definite move in that direction, and the funders are definitely moved in that direction too, because it has quicker impact. So I think it's positive. I think it's also being brave, really, to do that kind of work. It takes a bit more energy, I think, but also to be, particularly probably in end of life and palliative care settings, to be able to be in there activating change as you do research, and making that difference, requires quite a lot of skills and a good team, but I think it's really important and really key to supporting, as Matthew said, capacity and capability and research culture change at the same time.
I think the only thing I'd add to that is just the pain that it takes so long to get that research evidence into practice, no matter whichever specialty you're in. It's usually a good 15 years before that research becomes into practice, particularly to get it into the likes of NICE guidelines. So it is a frustratingly slow process, no matter what specialty. But having only worked in palliative end-of-life care for the last 6-7 years, I've been really struck by how much research is going on that's really focused on changing patient care. And if I think about just the work that we do within our own hospice, we have a NIHR study looking at the intimacy needs of people and their close partners at end of life. We're looking at the needs of people living with inflammatory arthritis towards end of life. And I'm very aware that across the country, there's so much work that's really focused about patient needs and people that we're caring for. So I think it is going on. It just can feel painfully slow before you finally see it as a national guideline. But yeah, we just need to keep doing more research. And the more of us who are busy doing that, then the greater that impact will be and the quicker that impact will be.
Thank you. And then there's a question for me, but if we can share it, that would be wonderful. What are the biggest challenges when building capacity? I can start by a lot, in research, there's a lot of new systems and a lot of processes which aren't familiar to people. And even though it's easy to say, find a small grant in your local R&D department, that assumes people know where that department is, who it is, what the grant looks like, how to shape a grant so it becomes competitive, and then how to manage, if it's successful, how to manage that into the kind of team and how to backfill time and all of those challenges. So there are many new systems, and to overcome that challenge, you just need to, sometimes the mentorship is about navigating these kind of organizational challenges and navigating through the processes. So I'll start with that one, and then maybe Susie, you could add one more.
Yeah, I think probably for me, the biggest challenges are workforce issues, both in practice and in the higher education settings as well. So I think there are challenges in terms of lack of lack of academics. And I think we're feeling, and hopefully that will change, but I think there is definitely a sense that we've lost people and there's a lack of that support within. But also I think there's a challenge challenge in the healthcare and the voluntary sector and hospice charitable sector too, isn't it, in terms of staffing. So I think working through that together is really important to support that. And sometimes when there's those challenges, it does provide opportunities as well. So I think it's about navigating that and working with people at all levels of the organisation to try and support those opportunities, particularly in terms of creating new roles and doing things differently.
Thanks. Candy, anything to add?
I think possibly the short-term contracts that happen within research are a constant challenge, and also those peaks and troughs of successes and failures, and that's when it's really important that you've got people who really have your interests at heart and really want to support you through that time when perhaps something isn't funded and it feels really tricky, but I know that all three of us will have had many things that were not funded, and that's the nature of research. So it's just having that resilience, but also having that support to help you get through and to move on to the next thing. So yeah, I think those are probably the biggest challenges, those fixed term contracts and the fact that not everything always gets funded.
Thanks, Candy. And in the chat, I've put, is it open access? There's a very positive opinion piece come from David Jones and Anne-Marie Keenan, who were the most senior positions in the NIHR Academy, and that's specific to nurses and midwives and allied health professions. Susie, you can close.
Yeah, well, that's a great place to end, isn't it? And just to thank, the speakers, to Matthew and Candy, but also all of you to be still here at 4 o'clock and for your contributions and for listening. And hopefully you've been inspired to go and, look at some of those resources that we've given you and maybe to join the Palliative Care Research Incubator, because I think that's a good place to start if you're looking for support. And just to remind you that there's going to be a recording of the session available on the platform later today, so you should be able to pick most of the information from that. But do get in touch with Mary Curie if you've got any more questions, and also get in touch with us. I'm sure we'll be happy to answer any queries down the line. Thank you very much.
Thank you.
Bye.